Every diet says eat more fruits and vegetables. Your smoothie has spinach, banana, avocado. You made it this morning. But past a certain stage of kidney disease, that single glass can push one mineral closer to a level your heart cannot safely handle. The mineral is potassium. Your kidneys are supposed to drain it, and if they can't drain it fast enough, it doesn't matter how clean the ingredients are. A team of researchers led by Domenico Gianese and Adamasco Cupisti at the University of Pisa published a study in the journal Nutrients in May of 2023. They followed 138 consecutive kidney disease patients, average age 60, all at stage 3 or stage 4. What they found was this. In patients taking a class of kidney protective medications called RAAS inhibitors, the ACE inhibitors and ARBs that most people at this stage are already on, the kidney's ability to drain dietary potassium was measurably reduced, even when the diet looked controlled. The drain was slower than anyone had accounted for, and the patients had no idea. So here's the answer right now. The mineral is potassium. A healthy blood level sits between 3.5 and 5.0 millimoles per liter. Above 5.5, the cardiac risk climbs. Above 6.0, the risk of a dangerous heart rhythm disturbance rises sharply. A standard smoothie built from a banana, a handful of spinach, half an avocado, and a glass of orange juice can deliver somewhere between 2,000 and 3,000 milligrams of potassium in a single glass. For a stage 3B kidney, the commonly recommended daily limit, when restriction applies, runs around 2,000 to 3,000 milligrams total for the entire day. That one smoothie may have already spent it. That is the headline. What it means at your specific stage, whether it applies to you at all, and what you say to your doctor about it, that is what the rest of this hour is for. Because knowing the name is not enough. The people who get hurt by this are the ones who either never hear the number or hear it and don't know how to use it. You are in one of two places right now. Either your potassium has been checked and it is in the normal range and nobody has told you to change a thing, in which case this hour is about understanding why that matters and staying ahead of it, or your potassium hasn't been discussed, your smoothie habit hasn't come up, and nothing has connected those two things in the same conversation. Which door is yours? The only way to find out is to know your actual number. By the end of this hour, you will know 3 things. You will know the exact number to ask for at your next appointment and what the answer means at your stage. You will know the name of the mechanism that makes this a kidney problem rather than a general nutrition question. And you will have the sentence, word for word, that gets your potassium and your diet into your chart so it travels with you to every doctor from here forward. If you have your last kidney labs in front of you, pull them out now. If not, picture the number your doctor mentioned. We are going to need it. You know the room. A clinic off Route 41, somewhere near Sarasota. Tuesday afternoon. You're in the chair and the printout is already on the desk. The nurse took your blood pressure. The doctor comes in, scans down the panel, eGFR holding, creatinine stable, nods, clicks to the next screen, and he says, "Keep doing what you're doing. Your numbers look stable." And he's already moving. And you think, okay, good. I've been doing the smoothie every morning, extra spinach, banana for the heart. That's what every wellness article says. And you drive home on Route 41 thinking you've got it handled. But there is one number on that panel you never looked at, and nobody pointed to it, and you didn't know to ask. There are 3 kinds of people watching this right now. The first group got a stage 3 diagnosis in the last year or 2, and has been trying to do everything right. Cleaner diet, more water, fewer processed foods. They found the smoothie on a kidney health list or a heart health list, and it seemed obvious. Fruits, vegetables, no added junk. They feel like they are ahead of this. What they don't yet know is that one number on their panel tells them whether ahead of this is actually true, and it's not eGFR. The second group has been managing this for years. Their eGFR has been stable, their creatinine is where it should be, they take their medication, they keep their appointments. They are not looking for an alarm. What they are looking for is the specific thing that a stable trajectory can still miss, the variable that runs quietly alongside all the numbers their doctor is watching. This is that variable, and it runs in the background regardless of how well the other numbers look. The third group is skeptical. They have heard enough about what they can't eat. They have been told to restrict this and avoid that, and they are tired of a list that only gets longer. What they want is not another rule. What they want is a mechanism, a reason that makes sense, so that any adjustment they make is something they understand rather than something they were told. That is exactly what this hour delivers. No matter which of the three you are, the mechanism underneath is the same. And it starts with a mineral that almost every kidney patient has heard of, but almost nobody has been told to specifically watch inside a smoothie. Potassium is a mineral your body needs. It helps your muscles contract, helps your nerves fire, and plays a direct role in keeping the rhythm of your heartbeat steady. A healthy body runs a tight balance. Not too much, not too little. And the organ responsible for keeping that balance is your kidney. The kidney is, in this specific sense, the drain. Everything you eat contains some amount of potassium. Your body absorbs it, uses what it needs, and passes the rest to the kidney to be cleared out in your urine. When the kidney is healthy, this happens continuously, automatically, and without any conscious effort on your part. When it is not, when filtering capacity drops, as it does in stage 3B and stage 4 chronic kidney disease, that drain slows. The potassium your food delivers keeps arriving. The drain that clears it cannot keep up, and so it backs up in your blood. The governing guidelines for kidney disease, the 2024 KDIGO Clinical Practice Guideline, authored by Levin and colleagues and published in Kidney International, make a specific point about this. They distinguish between patients with and without a history of elevated blood potassium. For patients at higher risk, the guideline specifically recommends limiting foods rich in what they call bioavailable potassium, meaning potassium the body absorbs quickly and completely. That phrase, bioavailable, is the key to why a smoothie is a different kind of problem than the same ingredients eaten whole, and we will get to that mechanism in a moment. But first, the foods on that list, because this is where the healthy food trap lands hardest for a stage 3B or stage 4 kidney. Bananas, oranges and orange juice, avocado, spinach, particularly when blended or cooked, tomatoes, sweet potatoes, coconut water, nuts and nut butters, dried fruit, raisins, dates, apricots, beans and lentils, dairy, milk, yogurt. These are not fringe foods. They are the backbone of virtually every dietary recommendation a 60-year-old will encounter. Heart-healthy eating, Mediterranean diet, anti-inflammatory eating, cancer prevention, general longevity advice. Every one of them is high in potassium. And every one of them in a kidney that is not draining at full capacity contributes to the same accumulation problem. The smoothie is not uniquely dangerous. It is the most efficient delivery vehicle for that problem because it concentrates multiple high potassium ingredients into a single serving that takes under 5 minutes to consume. Here is the number that makes this concrete. A banana carries roughly 420 milligrams of potassium. A cup of raw spinach is around 167 milligrams. Blended and packed tightly, a smoothie serving runs higher. Half an avocado adds about 360 milligrams. A cup of orange juice brings another 370 milligrams. Add a tablespoon of almond butter, another 200 milligrams. That single glass, assembled from ingredients every wellness source on the internet endorses, delivers somewhere between 1,400 and 2,500 milligrams of potassium before the morning is over. The commonly referenced daily limit for a stage 3B kidney patient whose potassium level is running high or whose medication is affecting clearance runs around 2,000 to 3,000 milligrams for the entire day. That smoothie may have spent the better part of the entire day's budget before breakfast is finished. Now, and this is the most important nuance in this hour, this does not mean that every person watching this needs to put down the blender immediately. The 2024 KDIGO guideline is specific. Routine potassium restriction is not recommended for kidney patients whose blood potassium level is normal and who do not have a history of it running high. What the guideline says is that when risk is present, at stage 3B or beyond, in anyone on a RAAS blocking medication, in anyone who has already had a high potassium reading, the dietary pattern needs to account for what the kidney can actually clear. The problem is not that smoothies are universally contraindicated. The problem is that almost nobody has that conversation. The potassium question doesn't get asked. The smoothie habit never comes up. And the labs that would answer it, the serum potassium, the result that tells you exactly where your number sits, often aren't interpreted in the context of what the patient ate for breakfast. A team at the University of Pisa in the 2023 nutrient study put numbers to this. Their 138 patients at stage 3 to 4 were all nutritionally stable. The researchers were testing whether urinary potassium, the amount leaving in the urine, was a reliable marker of how much potassium a person was actually eating. In patients not on kidney protective medications, it tracked reasonably well. In the patients on RAAS inhibitors, ACE inhibitors, ARBs, the medications most stage 3B and stage 4 patients are already prescribed, the relationship broke down. The RAS inhibitor group was clearing less potassium in their urine than their diet predicted. The medication that is protecting their kidney is, as a secondary effect, reducing the kidney's ability to excrete the same mineral that accumulates when the kidney slows. This is not a side effect in the alarming sense. It is a known manageable interaction. But it is one that requires knowing your number and knowing your habit. And most patients have been told about neither. This is where the drain analogy becomes most useful. Picture a drain that is already running at 60% of its normal rate. That is roughly the filtering capacity of a stage 3B kidney. Now picture that the pipe itself has been partially relaxed by a medication that sits at the opening of the drain, doing its job of protecting the filter above it. The drain still works, but its clearance rate is lower than it would be without the medication. And every morning, 1,000 or 2,000 milligrams of potassium arrives in a single glass and asks to be cleared through that drain in the next few hours. The drain manages until the number on the panel starts to creep. And by the time it creeps visibly on a lab result, it has often been creeping for a while. The clinical picture supports this. In a large UK cohort study that followed 191,964 CKD patients, real patients in clinical practice, over 45% experienced at least one episode of elevated blood potassium. The majority of those episodes were in the mild to moderate range, blood levels between 5.0 and 6.0 millimoles per liter. That is the range where symptoms are often absent. No palpitations, no weakness, no warning. The heart rhythm disturbance risk accumulates at a threshold that produces no signal the patient can feel. A systematic review cited in the Journal of the American Heart Association analysis of stage 3B and stage 4 CKD patients found that levels between 5.5 and 6.0 were associated with a statistically meaningful increase in major adverse cardiovascular events, defined as heart attacks, strokes, and cardiovascular deaths. Not in patients with wildly out-of-control kidneys, in patients at exactly the stage most people watching this are managing. This is not offered as an alarm. It is offered as a number. The number is 5.5. Below it, the risk profile looks different. Above it, the cardiac picture changes. And the number that tells you where you sit, your serum potassium, your blood potassium level, is on every kidney panel. It is already there. It has probably already been drawn. What is missing is not the test. What is missing is the conversation that connects that number to the glass on the kitchen counter. This isn't a prescription. Your exact potassium limit, whether you need to restrict it, how much, which foods matter most for you, depends entirely on your current blood potassium level, your specific stage, your medications, and your most recent labs. Bring what you learn in this hour to your kidney team before you change your diet. The goal is a better appointment, not a self-guided experiment. The question you are probably asking now is, if this mineral backs up without warning and the foods delivering it are the ones everyone says to eat, what exactly happens inside a kidney that is losing its ability to drain it? The mechanism is more specific than you have been told, and once you understand it, you will know exactly why general advice doesn't account for your stage. That is where we go next. To understand why potassium behaves differently in a stage 3B or stage 4 kidney, you need to understand what a kidney actually does with it, step by step, starting from zero. Your blood circulates through your kidneys continuously. Each kidney contains roughly 1 million tiny filtering units called nephrons. Picture a million miniature sieves, each one smaller than the diameter of a human hair. Each nephron has two parts: a filter at the top, called the glomerulus, where the blood is pressed through and the initial filtrate is separated out, and a long winding tube below it called the tubule, which is where the fine-tuning happens. The filtrate that comes through the glomerulus is a rough draft. It contains things the body needs to keep, things it needs to discard, and everything in between. The tubule's job is to read the rough draft and make decisions. Reclaim this, discard that, hold this for later. Potassium is processed almost entirely in the tubule. After the initial filtration, most of the potassium in the filtrate is actually reclaimed by the early part of the tubule, pulled back into the body before it leaves. Then, further down the tubule, the kidney makes its real potassium decision. Based on how much potassium is currently in the blood, it either secretes additional potassium into the filtrate to be excreted in the urine, or it holds back. This secretion step, the deliberate pushing of excess potassium out of the blood and into the urine, is the drain. It is active. It requires functioning tissue, and it is governed by a hormone called aldosterone that signals the tubule to work harder or ease off. In a healthy kidney, this system is exquisitely precise. Eat a high potassium meal, blood potassium rises slightly, aldosterone surges, the tubule secretes more potassium into the urine, and within a few hours, the blood level is back in the normal range. The drain opens wider on demand, the system has enormous reserve, you can eat a banana and your heart never knows it happened. In a stage 3B kidney, somewhere between 45 and 60% of those nephrons are gone. The ones remaining are working harder to compensate, a concept called hyperfiltration, the same overwork mechanism that drives CKD progression generally. But here is what hyperfiltration cannot fully compensate for: the secretion capacity in the tubule. As nephron mass falls, the total tubular surface available for potassium secretion falls with it. The drain physically has fewer channels. It can still work, but its maximum throughput is reduced. And unlike the filter rate, the eGFR, which the remaining nephrons can partially compensate for by working harder, tubular secretion capacity is more directly tied to the number of nephrons actually present. The drain is slower, and it cannot fully make up for the deficit by running the remaining channels harder. Now layer in the medication. CE inhibitors, drugs like lisinopril, enalapril, ramipril, and ARBs, drugs like losartan, valsartan, irbesartan, are kidney protective medications prescribed to most patients at stage 3B and beyond, particularly those with protein in their urine. They work by blocking the renin-angiotensin-aldosterone system, a hormonal cascade that, among other things, governs that aldosterone signal that tells the tubule to secrete potassium. When you block this system, which is the goal because blocking it also drops the internal pressure inside the filter and reduces protein leak, you also reduce the aldosterone signal. Less aldosterone means less urgency to secrete potassium. The drain slows further, not to zero, not dangerously in isolation, but measurably and in combination with reduced tubular capacity. The combined effect is a drain that is running at a fraction of what it once was. This is the finding the PISA team documented in their 2023 study. The patients on RAAS inhibitors were not excreting as much potassium in their urine as their diet predicted. The gap was not dramatic enough to land in the clinical danger zone for most of them. But the gap was real. It is the gap between the drain's capacity and the load the diet is placing on it. And if you are adding 2,000 milligrams of potassium in a single smoothie to a drain that is already running at reduced capacity on both counts, fewer nephrons and a RAAS blocker reducing the aldosterone signal, the math is straightforward. The number creeps. The word creep is the right word. This is not an acute event in most cases. It is a gradual drift in a number that is already on your panel, that has already been drawn, and that sits there between eGFR and creatinine without ever being discussed in the context of what you had for breakfast. A blood potassium of 4.8 becomes 5.1 over 2 or 3 lab cycles, then 5.3. Then 5.5, the number above which the cardiac risk picture changes. At no point during that drift is there a symptom. No warning, no signal. The drain is quieter than that. Here's the detail about blending that earns its place. When you eat a banana whole, the fiber matrix of the fruit slows the absorption of potassium into the bloodstream. The potassium is released gradually as the fruit is digested, and the kidney has time to manage the incoming load across several hours. When you blend a banana with spinach, avocado, and orange juice and drink the result in 4 minutes, the fiber is broken down, the potassium is released faster into the bloodstream, and the peak of potassium entering your blood arrives more suddenly. The drain has to handle a larger dose in a shorter window. This does not make blended fruit toxic. It makes the bioavailability, the speed and completeness of absorption, meaningfully different from the same ingredients eaten whole and slowly. The 2024 KDIGO guidelines language about bioavailable potassium is pointing at exactly this, not at fruit in general, at the delivery format and the pace. There's a second layer that is worth naming, even though it is not the headline mechanism of this hour. Several common smoothie additions, yogurt, cow's milk, nut butters, seeds, carry a second mineral that a stage 3B or stage 4 kidney also struggles to clear, phosphorus. Phosphorus is the other mineral managed by the kidney, and retained phosphorus has its own downstream problem. It triggers a hormonal cascade that pulls calcium from bone and deposits it in artery walls. That is a separate video, but it is worth knowing that a smoothie loaded with yogurt and almond butter is not just a potassium delivery vehicle, it is also contributing to the phosphorus load. Both minerals are on the same panel. Both are worth asking about at your next appointment. Back to potassium, and to what the number creeps actually looks like from the inside. Consider what the stage 3B kidney is actually managing during the hours after that morning smoothie. The potassium load arrives in the bloodstream. The blood level rises, not drastically, but by a measurable margin. The remaining tubules respond, secreting potassium into the urine as fast as they can. The RAAS medication dampens the aldosterone signal that would normally amplify that secretion. The peak of potassium in the blood sits slightly higher and slightly longer than it would have in a healthy kidney, and then the next day's smoothie arrives and does it again, and the next day, and the next. Over weeks, over months, the accumulated effect of that daily ceiling on clearance and that daily load on delivery begins to register on the panel. The number that the doctor glances at between eGFR and creatinine drifts past 5.0. Nobody comments. Nobody connects it to the blender. This is not a failure of medicine. It is a failure of information reaching the right place at the right time. Your kidney doctor is not ignoring the potassium number, but in a 15-minute appointment covering your eGFR trend, your blood pressure, your medications, your protein intake, and your list of questions. The smoothie habit is not a variable that enters the room unless you bring it. Nobody asks. You don't think to mention it. And so the number drifts in a chart that no one is reading as a story, only as a row in a table. Close your hand around your last kidney report for a moment. The number you want is labeled potassium, or serum K or K+. It is there. It is already there. The safe range is 3.5 to 5.0 millimoles per liter. Below 5.0 and without a history of it running high, you are in the zone where restriction is not routinely indicated. And that is important to know because restricting potassium unnecessarily carries its own risks, including pushing the number too low. Above 5.0, a conversation is warranted. Above 5.5, the conversation is not optional. Here is your first action. Find that number on your most recent panel. Write it down. If you don't have a recent panel, make a note to ask for one, specifically the comprehensive metabolic panel or the basic metabolic panel, both of which include serum potassium. That number, combined with your stage and your medication list, is the information your kidney team needs to tell you whether your smoothie habit is a problem, a non-issue, or something in between. Without the number, the conversation cannot happen. With it, the conversation takes 3 minutes and produces an answer. The question that comes next is the one that almost nobody answers in a way that actually helps. If this mechanism is this clear, drain slows, potassium backs up, no symptom, number drifts, why hasn't your own kidney doctor mentioned the smoothie? The answer is not what you expect. And it is not a reason to be angry. It is a reason to understand the structure of the system you are navigating and to walk into your next appointment prepared to close the gap yourself. Why hasn't your own kidney doctor mentioned the smoothie? It is the right question. And the answer has nothing to do with negligence, indifference, or your doctor not knowing the research. The answer is structural. And once you understand the structure, the question stops being frustrating and starts being useful. Consider what a typical nephrology appointment looks like. A review of your latest labs, eGFR, creatinine, potassium, phosphorus, bicarbonate, protein in the urine, a blood pressure check, a review of your medication list, a brief assessment of how you are feeling. Questions about swelling, shortness of breath, appetite, and then whatever you brought in to ask. All of that, for a stage 3B or stage 4 patient who is otherwise stable, happens in somewhere between 15 and 25 minutes. That window has to contain everything, not just the numbers in front of the doctor today, but the trend behind them, the medications that might need adjusting, the referrals that might be needed, and the complications that need to be screened for at your specific stage. In that window, diet comes up the way it comes up in every clinical setting, in pattern language. Reduce sodium, watch protein. Ask your doctor about potassium if you have questions. That last item, ask your doctor about potassium if you have questions, is the instruction that assumes you already know what question to ask. It assumes you know that the smoothie is a potassium delivery vehicle. It assumes the connection has already been made somewhere between the exam room and your kitchen. And for the overwhelming majority of patients, it has not. This is not a failure of your nephrologist. It is a failure of where the conversation is designed to start. The nephrologist is working from your labs. If your potassium has been sitting at 4.6 for 3 consecutive draws, the urgency of a diet conversation about potassium is low. The number looks managed. What the number does not tell the doctor is that you are drinking 2,000 milligrams of potassium every morning in a glass that takes 4 minutes to consume, and that the only reason the number has held at 4.6 is that your kidney is still compensating, still draining just fast enough to keep the result inside the reference range. The room between where you are and where the number starts to move is invisible on the panel. The doctor is not looking at the room, the doctor is looking at the result. There is also a lag between the research that generates a clinical nuance and the moment that nuance reaches the guidelines, and then a second lag between the guideline update and the moment it reaches routine clinical practice. The 2024 KDIGO guideline, authored by Levin and colleagues and published in Kidney International, is the first major revision of the CKD management standard to include explicit language about bioavailable potassium, distinguishing between the potassium in whole, unprocessed plant foods, and the potassium in highly processed or rapidly absorbed forms. That is 2024. The general dietary advice most patients encounter, eat more fruits and vegetables, potassium is good for your heart, was built over decades of population-level research on healthy adults. It was never tested on a stage 3B kidney paired with a RAAS inhibitor and a morning smoothie habit. The mismatch between those two bodies of evidence has been sitting in the literature. It has not yet reached the exam room in plain language for most patients. That lag is the structural failure, not the nephrologist. The nephrologist is working with the pattern the system trained them to run. A 15-minute appointment, a panel of results, a checklist calibrated for the average patient at this stage. Your smoothie is not on the checklist, not because it is unimportant, because the checklist was not built with your kitchen in mind. The only way the pattern updates for you specifically, and before the guidelines work their way into routine practice at the primary care level, before the general dietary messaging catches up with the stage-specific nuance, is if someone brings the new information into the room. That someone is you. Not with a printout, not with an argument, not with a demand, with one sentence. And that sentence is what the next section of this hour is about. You now understand why the smoothie conversation has not happened. The question is how you make it happen. In the next appointment, in plain language, in a way that gets a useful answer and gets that answer documented where it needs to be. That starts with one sentence. Before you walk into the exam room, there are 3 pieces of information you want in your hand. The first is your most recent serum potassium number, the result labeled K or K+ on your lab panel. The second is your current stage, the eGFR, that tells you and your doctor exactly where your filtering capacity sits right now. The third is your medication list, specifically whether you take an ACE inhibitor, an ARB, or any medication that your pharmacist or doctor has described as a kidney protector or a blood pressure medication that also helps the kidneys. With those 3 things, you have everything the conversation requires. You do not need a medical degree. You do not need to understand every detail of the mechanism. You need one sentence, and then you need to listen to the answer. The sentence is this: I've been having a smoothie most mornings with banana, spinach, and avocado, and I wanted to ask whether my potassium level and my current stage mean that's something we should look at more carefully. That is it. That is the whole opening. It is not confrontational. It is not a challenge. It is a specific, factual, self-referred piece of information that gives your doctor exactly what they need to give you a real answer. What you eat, the mineral it delivers, and the question of whether your current number and stage put you in the territory where that habit matters. A doctor who hears that sentence has three paths forward. Each of them is useful. The first path is, your potassium is well within range, your stage doesn't currently indicate restriction, and the smoothie is not a problem. In this case, you have confirmed something that removes uncertainty. You now know the smoothie is not the variable you need to worry about, and you know what number to watch, so that changes. That is not a wasted appointment. That is exactly what monitoring is for. The second path is, your potassium is trending in a direction that warrants attention, or your stage and medication combination puts you in the category where the KDIGO guideline recommends being thoughtful about bioavailable potassium. In this case, your doctor can give you a specific target, a number, a range, and recommend that you talk to a renal dietitian who can walk you through exactly which ingredients to modify and which alternatives keep the ritual intact. The smoothie does not necessarily go away. The ingredients change. The third path is, your potassium is above 5.0, and this conversation is more urgent than you realized. In that case, what you have just done is connected a lab result that may have been sitting quietly on your panel to a dietary habit that is contributing to it. Your doctor can now act on that connection, not because the connection is new to medicine, but because you put it in the same room as the number. After the initial question, there are two follow-up requests. The first, what is my current potassium number and what would be the target range to aim for at my specific stage and with my medications? This establishes the number in your mind, not just on the panel. A number you know is a number you can track. A number that sits in a chart you never look at is just a row in a table. The second follow-up, would you be comfortable referring me to a renal dietitian specifically to review my diet for potassium and whether anything else in what I eat is adding to that load? A renal dietitian, not a general nutritionist, a renal dietitian is the clinician whose specific expertise sits at the intersection of kidney function and food safety. They know the stage-specific limits. They know which items on your usual grocery list cross lines that general nutrition advice doesn't draw. They know the substitutes that keep eating feeling like eating rather than like a medical regimen. And then the sentence that earns its place at every appointment you will ever have from this point forward. The keystone, the one that makes everything you learn portable. Would you be comfortable noting in my chart that I asked about potassium management and my current diet? Specifically, whether my potassium level and my stage mean I should be watching how much I get from foods like smoothies. And what we decided? That sentence does one specific thing. It puts the conversation in the chart. A conversation that is not in the chart did not happen. Not officially, not in a way that travels with you to a different provider, a different city, a different specialist, an emergency room on a Wednesday night when your regular doctor is not available. The chart is the document that follows you. Every relevant decision needs to be in it. The keystone sentence is how you make sure it gets there. One more tool before you leave the appointment, ask for the explicit do not do guidance on potassium salt substitutes. These products, marketed as lower sodium alternatives and sold in the spice aisle of every grocery store, replace sodium chloride with potassium chloride. They are not low sodium. They are high potassium. For a stage 3B or stage 4 kidney managing its potassium load, a potassium chloride salt substitute adds a concentrated potassium hit to every meal that uses it. It does not require a smoothie. It does not require a banana. It is a direct, highly bioavailable potassium source in the form of what looks like ordinary table salt. Your doctor or renal dietitian will tell you to avoid it, but you have to ask because it rarely comes up otherwise. What you are not going to do at this appointment: argue, present evidence, challenge the clinical judgment in the room, or threaten to change providers. Not because those feelings are wrong if you have them, but because they close the door on the conversation you came to have. Your doctor is not withholding information to protect a system. They are running a pattern that the structure of healthcare trained them to run. You are not there to correct the pattern. You are there to extend it, to add one piece of information the pattern didn't have before you walked in. The conversation that results from that is worth far more than the one that starts with frustration. Sit back for a moment. Picture this. It is 6 months from now. You walk into the same clinic off Route 41. You're in the same chair. The printout comes across the desk, and this time there is a note in your chart from the last visit. A line that says you asked about potassium and dietary management, what was discussed, what was decided. Your doctor glances at the note, looks at your most recent potassium number, and because the conversation happened, because the habit changed, because the renal dietitian walked you through the substitutions, the number is where it should be. It has not crept. It is not trending. It is stable. And the doctor says, your potassium looks good. Whatever you've been doing, keep doing it. And this time, when you drive home on Route 41, you know exactly what you're doing. You know why it's working. And that knowledge does not expire at the end of this visit. It travels with you to every appointment, every panel, every lab result for the rest of your life. Now picture the second version, same chair, same printout, no note in the chart, no conversation logged. And the potassium number is 5.4, either above 5.0, trending up in the range where the cardiac risk begins to accumulate. The doctor notes it, adjusts something, tells you to come back in 3 months. No one asks about the smoothie, because no one knew to ask, because the conversation never happened. You are not in either of those futures yet. You are between them, and the only thing that separates them is whether you bring the sentence into the room. The identity you are stepping into is not a medical expert. It is simpler than that, and it is more durable. You are the person who knows that general health advice needs a stage tag before it applies to your kidney. That is the whole thing, not a list of forbidden foods, not a fear of the blender, not a conversion to a medical diet that removes everything that tastes like anything. Just one skill. When a wellness source tells you something is healthy, you know to ask. Healthy for whom? At what stage? With which medications on board? That question has an answer. The answer is specific, and the specific answer is what protects you. This skill travels to everything on your panel, not just potassium, not just the smoothie, phosphorus in the yogurt you add to the blender, protein load from the shake you have after a walk, sodium in the broth you use for soup. Every number on your kidney panel has a dietary input that most of your health advice was not calibrated for. You now know how to find it, how to name it, and how to get it into the chart where it belongs. The smoothie was the example. The skill is what you take home. Now for the 5 questions that bring you the rest of the way there. The first, can you still have smoothies if you have CKD? This depends entirely on your potassium number and your stage. For stage 3A patients with normal potassium who are not on RAAS medications, a smoothie made with lower potassium ingredients, berries instead of banana, baby spinach swapped for a small amount of mild lettuce, no avocado, a splash of cranberry juice instead of orange juice, and unenriched rice or almond milk instead of yogurt, carries a meaningfully lower potassium load and may be entirely fine. For stage 3B patients or anyone with a potassium above 5.0 or anyone on an ACE inhibitor or ARB, the ingredient list needs to be reviewed by a renal dietitian before it is assumed to be safe. The blender is not the problem. The specific ingredients at your specific stage, with your specific number, are the question. The answer is individual. This isn't a prescription. Your exact limits depend on your current labs and your stage. Bring this to your kidney team before you change your diet. The second, what are the lower potassium swaps that still make a smoothie worth having? At stage 3, B to 4, when potassium restriction applies, the foundation shift is berries for banana. Blueberries, strawberries, raspberries all carry roughly 100 to 150 milligrams of potassium per serving, compared to the 420 milligrams in a banana. Grapes and apple slices are also in the lower range. For the green component, a small amount of very lightly packed iceberg or green leaf lettuce adds color and volume without the potassium that spinach or kale carries. For the liquid base, unsweetened cranberry juice or a label-checked unenriched almond or rice milk replaces orange juice and yogurt, eliminating two of the highest potassium contributors in a single step. The result is a drink that still functions as a morning ritual. The potassium load drops from a potential 2,000 milligrams to somewhere in the range of 3 to 500 milligrams for the full serving, a number a stage 3B kidney managing its potassium can typically handle without strain. Confirm these specifics with your renal dietitian before you rebuild the recipe, because your exact limits belong to your labs, not a general estimate. The third, what if my potassium always looks normal on my labs? Does this even apply to me? It may not. And this is the nuance the 2024 KDIGO guideline specifically protects. If your potassium has been consistently in the 3.5 to 5.0 range and your stage is early, stage 3A EGFR above 45, no RAS blocking medications, the current evidence base does not support routine potassium restriction. Restricting unnecessarily carries its own risks. Potassium that is too low can also affect heart rhythm, and over-restriction leads to a narrower, more fear-based relationship with food that reduces nutrition quality overall. The appropriate response to a normal potassium is not to restrict. It is to know the number, continue monitoring it, and understand that the smoothie conversation becomes relevant if the number moves above 5.0, if your stage changes, or if a RAAS medication is added. The number you don't know is the one that can drift without you. The fourth, does my blood pressure medication affect how much potassium I can handle? Yes, and this is the mechanism most patients have never been told about. CE inhibitors and ARBs, the standard kidney protective blood pressure medications at stage 3B and beyond, work partly by reducing the activity of a hormone called aldosterone. Aldosterone is the signal that tells the kidney's tubules to secrete more potassium into the urine. Reduce the aldosterone signal, and the kidney's ability to dump excess potassium slows. This does not mean the medication is harmful. It is kidney protective, it reduces protein in the urine, and it slows progression. But it does mean that a patient on one of these medications has a smaller margin between their dietary potassium load and the level at which blood potassium starts to creep. Finerenone, a newer medication used in some patients with diabetic kidney disease, blocks a related hormone pathway and also affects potassium handling. Do not stop, start, or adjust any of these medications based on this video. The goal here is understanding, so that when the potassium conversation happens with your team, you can ask specifically whether your particular medication is affecting your clearance and whether that should change how you think about dietary potassium. The fifth, why are you telling me this, and what is the angle? There is no product, there is no program, there is no supplement this hour is building toward. The angle is the appointment. Every script on this channel delivers the same thing: a piece of clinical information that is accurate, that is grounded in named research, and that gives you a specific sentence to say in a specific room. The reason that information matters is that a 15-minute appointment with a kidney doctor cannot cover everything that matters to a patient at stage 3B who is also navigating wellness advice built for a 40-year-old without a kidney diagnosis. The gap between those two bodies of advice is real. Closing it requires someone who knows both sides are in the same kitchen. That is what this hour was for. The wider pattern underneath this hour is simpler than it looks. It is this: the information that governs what is safe for your kidney at your stage does not always reach the same channels that deliver general wellness advice. The smoothie is one example of a much larger class of situations where food advice designed for one audience arrives in the hands of another. The same pattern applies to salt substitutes, marketed as heart-healthy, genuinely dangerous for some kidney patients; to coconut water, marketed as a natural electrolyte drink, extremely high in potassium; to beans and lentils, among the most praised foods in every longevity study, and a concentrated potassium source for a stage 3B kidney that is already managing its load. to dark chocolate, to avocado toast, to the smoothie at the gym that the trainer hands you with confidence. None of those advisors are wrong for their audience. They are wrong for yours, without the stage tag. The skill this hour gave you is not a list to memorize. It is the habit of asking, was this advice built for my kidney at my stage with my medication on board? If the answer is not obviously yes, the question belongs in the chart. The mineral in the glass in the end is just the example. The label reading, the number checking, the sentence, those travel everywhere your kidneys go. You didn't need to know less. You needed one number, and now you have it. Look at that number on your last panel. The one you found earlier, the K or K plus in the row between the other results. That number already existed. It was already there. It was just waiting for the conversation to catch up to it. You are the one who walked in today and closed that gap. That is not a small thing. That is the whole thing. Write the potassium number down somewhere you will see it before your next appointment. Write the sentence down next to it, the sentence that gets it into your chart, into your record, into the document that follows you. Share this hour with the one person in your life who is also managing their kidney numbers and has never heard the words bioavailable potassium, because they are almost certainly drinking the same smoothie and have the same gap in the same chart. The next video from Dr. Elizabeth Blackwell on this channel goes to the other mineral your kidney struggles to clear, phosphorus, and the place it hides that no food label in America is required to print as a number. The connection between those two minerals and what they do together to bone and artery is the follow-up this hour deserves. Pacing direction. Avatar drops pace on the next line, full breath before delivery. You didn't need to know less.